Discussion is metabolic acidosis. We see ABGs in a day-to-day basis. So most of them have metabolic acidosis. That's why I picked up this topic to start. Then I'll later discuss about metabolic alkalosis, respiratory acidosis also. But we'll first, before going to the discussion, we'll understand how to interpret the ABGs. What are the parameters that you see in the ABG? How do you should differentiate between ABG versus VBG? What are the different things that will help you out in differentiate between HAGMA, NAGMA, and metabolic alkalosis, mixed parameters? There are many things we'll discuss before going into the case-based scenario like we previously in the previous session. In this session, we'll first understand the concepts behind understanding the ABG and what is acidosis, what is HAGMA, what is NAGMA. We'll understand all these concepts before discussing the case-based scenario approach. So first, the normal values you need to understand. The pH is 7.35 to 7. Mean is 7.4. PaO2 is 80 to 100. This is on the ABG. PCO2 is 35 to 45. Mean is 40. And bicarb is 20 to 26. That is 24. So pH of 7.4, PaCO2 at 40, and bicarb of 24 is the normal values we take for the ABG parameters. So how do you differentiate between arterial versus venous sampling? So in the case of arterial, the mean pH is 7. That lies between 7.35 to 7.4. Where the mean pH is 7.40. In the case of mixed venous sampling, the pH is a little on the lower side, much more of acidotic, that is 7.31 to 7.41, that is 7.36 is the mean. PaO2 80 to 100 is millimeters of mercury is seen in the case of arterial, whereas 35 to 40 millimeters of mercury is seen in the case of venous, that is oxygen saturation corresponds to 95 in the case of arterial, whereas 70 to 75 in the case of mixed venous. PaCO2 also, the mean value changes from 35 to 45, whereas it comes around, mean is around 40, whereas venous it is little on the higher side. Mixed venous little is on the like there are 45 to 46 is the normal venous CO2 value, that is 41 to 51. So this is how you differentiate the case of arterial versus venous by looking at the pH. One is pH is on the little acidotic, the 7.36 is the main. PaO2 is generally on the lower side, that 35 to 40 is the oxygen saturation, PaO2, that is 35 to 40 millimeters of mercury, and PaCO2 is on the little higher side, that is a mean value of 46. This is how you differentiate with the mixed venous sampling and arterial sampling, especially looking at the PaO2 value, where unless the patient is severely hypoxic or the patient is requiring ventilator, generally arterial PaO2 does not generally come below come down to a value of 35 to 40. So these are the values you see in the measured values which are normal actually measured are pH, PCO2 and PaO2. Remaining all the values, that is oxygen saturation, bicarbonate, electrolytes, these are all the calculated values from the different parameters. Only measured values on the ABG are pH, PCO2 and PaO2. So how do you analyze a pH? How do you analyze an ABG first? Now we already discussed in ABG, pH is 7.35 to 7.45 is generally normal. So you should always rule out whether the ABG or VBG is always important. Generally in the case of, by looking at the previous parameters, you need to differentiate ABG or V. I am discussing about the ABG. Anything less than pH less than 7.35 is considered acidotic. There is much of difference in the, generally only a 0.5 change is there. In the pH, that is difference between the venous and arterial, like we discussed previously. But less than 7.35 on ABG is considered acidemic. More than 7.45 is considered alkalemic in the case of ABG. If the normal range, let's say if the patient is having a pH is normal, let's say pH is 7.37, but bicarb is 13. You label it as a normal ABG? No. It is generally maybe the patient is having compensated because there is metabolic acidosis definitely, but it might be compensated. But maybe PCO2 is also decreased. PCO2 is around 20 or something. Maybe is compensating something. So just because pH is normal, you can't label the ABG as normal because there might be underlying compensated metabolic acidosis with respiratory alkalosis also. But how do you differentiate whether acidosis is the main cause in the case of compensated, whether acidosis is the primary pathology or alkalosis is the primary pathology? How do you differentiate it? For that, you look at the what side of pH it is there. Let's say 7.4 is the mean you took. Let's say 7.38. So the primary pathology is acidosis. Let's say pH is 7.43. The primary pathology is alkalosis. So what is the cause of alkalosis? What is the cause of acidosis? Secondary. But how do you label it? What is the primary pathology in the case of compensation is very important. In that case, hot side of 7.4 it is there. If it is 7 point less than 7.4, that is 7.36 or 7.37 that is there, that is acidotic. If it is more than 7.4, that is 7.42 or 7.43, that is alkalotic. The primary pathology is alkalosis, that is metabolic alkalosis or respiratory, that might be compensated by respiratory or metabolic acidosis. That is different thing. So what side it is there, it is alkalosis or acidosis, it will be decided on that. So look for PCO2 or PCO3. Once you decide, let's say pH is 7.36. Then you decide on what PCO2 and bicarbonate, whether the cause of acidosis is alkalosis or metabolic or respiratory. Let's say pH is 7.37, but bicarb is 16. So the primary pathology is metabolic acidosis. Then you look at the respiratory alkalosis, PCO2. It might be on the higher side. Maybe PCO2 is on the lower side, right? And the normal is P40, no? It may be 30 or something. So the metabolic acidosis is compensated with the respiratory alkalosis. The primary pathology pathology is metabolic acidosis. But in the same case, pH is 7.43 or something, but PCO2 is 20 and bicarb is 16 or something. In this, the alkalosis pH is 7.43, you definitely label it as an alkalosis, but the cause of alkalosis is a respiratory because PCO2 decreased, but bicarb is also decreased. Here, respiratory alkalosis is compensated with metabolic acidosis. So that is how you look at. You take 7.4, it is more than that, it is alkalosis. Then you look at the PCO2 and bicarb. If PCO2 is decreased, that is alkalosis. So that is the primary pathology. You look at bicarb, it is also decreased. Maybe respiratory alkalosis is compensated with metabolic acidosis. If pH is less than 7.4, the primary pathology is acidosis. The cause of primary pathology, you look at bicarb and PCO2. If bicarb is decreased, that is metabolic acidosis. If PCO2 is increased, that is respiratory alkalosis. Then you look at the compensation later on. So what caused the primary pathology in the case of normal pH, that is 7.35 to 7.44? You look at the what side of 7.4 it is done. Then you look at the bicarb and PCO2. Then you decide what is the cause of acidosis or alkalosis. Then you take on the compensatory cause. So let's say if both can explain. In the previous cases we have seen pH is if 7.35 less than 7, you definitely label it as well. You look at the mean cause, like 7.35 to 7.45, it is there. You look at what side of 7.4 it is there. Let's say 7.36 it is definitely acidosis if bicarbonate is low. Per se, there should be bicarbonate low or PCO2 excess. That should be the clause. If bicarbonate is low, it is definitely metabolic acidosis there. That is compensated with respiratory alkalosis or something. That's why pH is normal. In the same way, if 7.37 is pH is there, PCO2 is on the 70, but maybe bicarbonate is 24 or something. In that case, respiratory acidosis is compensated with metabolic alkalosis. That is why pH is normal within the normal limits. But that doesn't mean ABG is normal. That is compensated state. In the same case, 7.43 pH is there, and the patient is definitely having alkalosis. What is the cause of alkalosis? You look at the PCO2 and the bicarb. If the bicarb is 29 or something, metabolic alkalosis is the primary pathology. It might be compared to respiratory. Maybe PCO2 is also on the higher side. Maybe metabolic alkalosis is compensated the respiratory side. That is how you look at the interpret the normal pH. Maybe there is underlying bicarb abnormalities or PCO2. So just because pH is normal, it doesn't mean there is no underlying metabolic acidosis or alkalosis. So you look at the bicarb and PCO2 also, you interpret that way, and maybe there may be compensated state. So let's say in this case pH is 7.25, both are decreased. Bicarb is 16 and PCO2 60. So both can bicarb is decreased, PCO2 is increased. So in this case, bicarb decrease explains the metabolic acidosis, PCO2 increase also explains respiratory acidosis. So both of them explain the acidosis cause. So how do you tell which is the predominant cause? You then check for the percentage difference. So bicarbonate from the mean value of 24, you minus 16, 33% change is there. PCO2 mean value is 40, here 60 is there, the change is 50%. So respiratory acidosis is the predominant cause here. So that is how you define the cause of this is a respiratory acidosis with metabolic acidosis. So both are there. It's a mixed acidotic state. Both are there, but respiratory acidosis is the predominant thing. There is no compensation here. So then, in the case of normal, like you said, in the case of 7 point, sometimes the patient will have normal pH but deranged bicarb and PCO2. How do you look for the compensation? Whether it is properly compensated or not, you look for the compensation formulas. So pH will be 7.37 only, but the bicarb will be 13 or 14, but it is compensated by respiratory alkalosis where the PCO2 also decrease. How do you look for the compensation? So generally compensation occurs in the two ways: in a respiratory buffer response by eliminating the CO2, or renal buffer response by changing the excretion or retaining the bicarb or PCO2. So that is how it happens. Generally respiratory response occurs in minutes, 1 to 3 minutes it will generally occur, whereas the renal buffer takes minutes to hours to occur. So generally renal adaptive response will take minutes to hours to days, whereas respiratory generally occurs in minutes. So this is how you look at how compensation occurs. So for every 1 milliequivalent decrease in the case of metabolic case, for every 1 milliequivalent decrease in the bicarb, PCO2 also should decrease by 1.2 millimoles of mercury. So that is how you look at. So in the case of metabolic alkalosis, for every 1 milliequivalent increase in the bicarb, so PCO2 also should increase by 0.75 millimoles of mercury. So that's how the pH will be normalized in the case of them. So let's say the pH is 7.37 or something. Bicarb is, let's say for normal it is around 19 or something. So it is decreased by 5 milli. From the mean it is decreased by 5. So for 5 it will decrease by 5 into 1 point. The PCO2 also should decrease by 6 millimeters of mercury. In the same way in the case of metabolic alkalosis, let's say pH is 7.43 or something, the pH is normal, but bicarb is 29 or something. From average it increased by 5. So 5, for every 5 increase, the pH should be C0 point. That's how PCO2 also increased by 0.75 into 5 is 4. So PCO2 also increased by 4, that is 44 or something. So that is how it comes, that is why pH is normal. So in the same way, in the case of acute respiratory acidosis, that is where PCO2 is increased by 10 millimeters of mercury, bicarb increased by 1 milliequivalent. In the case of acute respiratory alkalosis, where the PCO2 is decreased by 10 millimeters of mercury, bicarb decreases by 2. In the case of any chronic respiratory acidosis or alkalotic state, the PCO2 for 10 millimeters mercury of PCO2 change, the bicarb changes by 4. I'll give an example. Let's say the patient of COPD patient presented with first time presented with respiratory acidosis, his PCO2 is 60 or something. So if the patient is compensated, the pH is normal. Compensation means the pH is normal, like 7.35 to minute. So his pH is 7.37 or something. Because bicarb increases by 1 milliequivalent for every 10 millimoles increase in PCO2. Maybe his bicarb is around 27, 28. He is well compensated. So that is how pH is normal. So that is how you calculate. For every 10 millimoles increase in bicarb, there will be at least 1 milliequivalent increase. For if it is pH is 40, it increases by 60, 20. So bicarb should increase by 2. So in the case of chronic respiratory acidosis, the patient is having long-term OSC or long-term CO2, COPD who is chronically state. In them the compensation is more so that the patient is used to normalize the pH. For every patient PCO2 is around 80 or something, there is 40 millimoles of mercury increase in PCO2. In them the bicarb also increase in the same way, the 4 into 10. So it's around 4 for every 10 4 is increased. Here the 40 is increased, 4 into 4. Maybe bicarb will increase by 16 in those cases. So that is how you evaluate. So in this case the PCO2 is 80 or something. The bicarb will increase by 16. Maybe the PCO2 is around 38 or bicarb will be around 38 or 40. Because for every 10 millimeters bicarb increase by 4. So in this there increase of 40. So 4 into 40. This 4 into for every 40, that is for every 10. So 40 it increases by 16. So from 24 it increases by 38 to 40. That is how it increases. In the case of a chronic respiratory alkalosis, it decreases by same way. So that is how you look at the compensation. So if there is any normal pH, you should always look whether it is properly compensated or not also. So this is the table you should definitely remember to look for the rule of compensation. So how you look at the anion gap? What is normal and what is anion gap per se? So the anion gap is in our serum. There are definitely, you can measure some cations, you cannot measure some cations. So there are measured cations and measured anions. So there are definitely unmeasured cations and unmeasured anions also. This difference, what is unmeasured anion gap? The difference between the anion gap, how much anions are present. The unmeasured anions minus unmeasured cation is, you measure cations, you have measured cations. That is how the difference between the unmeasured anions and unmeasured cations is the anion gap. So that is how you measure it by Na plus minus Cl by plus bicarb. So ignoring the formula per se, so what is the normal values? Tell anything around 12 plus or minus 4 is normal. If you take Na plus K plus minus Cl plus bicarbonate, then 10 plus or minus 2 is 12 plus or minus 4 when K plus is taken into the formula, that is Na plus K plus minus Cl plus bicarbonate. But if you take the K plus is omitted, in the case of this formula which we are using right now, 10 plus or minus 2 is considered normal. So what is normal anion gap metabolic acidosis and what is high anion gap metabolic acidosis? So high anion gap metabolic acidosis, ignoring that unmeasured anions, unmeasured cations, these are all like for the theory purpose. But what is the significance of this thing? So what is HAGMA, what is NOGMA, why it is occurring? In the case of high anion gap metabolic acidosis, this is due to the impaired that is acid excretion or some organic acids which are formed in the body which cannot be excreted outside. So in them, there is no compensation. This cannot be excreted. So the anion gap will be increased because there are some organic acids and H plus ions which cannot be excreted. So they result in the increased anion gap. That can be due to decay, that can be lactic acidosis, some toxins can cause. So these all cause which generate organic acids or some H plus ions which cannot be excreted in the kidney. So what is normal? Why there is normal anion gap metabolic acidosis? So generally what happens is, in the case of some cases of diarrhea or some renal tubular acidosis, there is some amount of bicarbonate loss. But in those cases, in the case of diarrhea or renal tubular acidosis, some diversion, that sigmoid diversion or something, though there is a bicarbonate loss, it is compensated by chloride conversion in the kidney. It is chloride conserving. So in them, though the bicarbonate loss there, it is compensated by conservation of the chloride in the kidney. So there is decrease in bicarb but increase in chloride, so it is combined in the formula, so there will be normal anion gap in this case. So Nagmeier is the condition where though there is a bicarbonate loss due to the renal loss or diarrhea loss, some the sigmoid diversion or something, wherever there is a bicarbonate, it is compensated by conservation of chloride in the kidney. That is why for decrease in bicarb there is increase in chloride in this kidney, so that for total anion gap will come down to normal. So that is the reason why there is a Nagma. In the case of Agma, this conservation is lost, is not there. So there is impaired excretion of organic acids or H plus ions. So there is no conversion. Both bicarb and chloride may be decreased, or some organic acids are increased per se. So in them there is no compensation or something, though there is increase in high anion gap. So these are cations and anions. These are measured cations. These are unmeasured cations. So these are unmeasured anions. Normal chloride. These are anions which comes in the bicarbonate chlorides, which normally use in the formula we use. So this is the concept of anion gap comes from this formula. We are generally measuring the difference between the unmeasured anions and unmeasured cation is what we are measuring. So if there is an increase in organic acids or something, some increased H plus ions, there is anion gap is generally increased. So the whole concept of Hagma and Nagma is based on the, if there is chloride compensation with the bicarbonate loss, so there will be increase in chloride with the decrease in bicarbonate, so it will come out to Nagma. If there is excessive organic acid which cannot be compensated, it results in the high anion gap metabolic acidosis. So what are the causes of Hagma and Nagma will come down to the next in the next slides. So this is how this is again unmeasured anions and unmeasured cations. I mentioned the formula. So this is the formula, but the understanding this is just for the theoretical purpose. What is the basic understanding you require? What is the difference between Hagma? In Nagma there is a chloride compensation. That is why there is there is normal anion gap. For every loss in bicarb, the chloride is conserved. That is why Nagma is there. In the case of high anion gap, there is no such conservation of chloride or anything. So there is increase in organic acids that is causing the increased anion gap. So that is all. This is also important. In the case of albumin, generally compose most of the anion gap. So generally for the patient who are hypoalbuminic, so generally anion gap also will decrease. So for every 1 gram per deciliter decrease in albumin, you should take 2.5 milliequivalents decrease in anion gap. So patient is CLD. So generally anion gap will be decreased in them because of the decrease in albumin. So because most of the anions are albumins, proteins only. So anion gap will be this cannot be, these are more. So for every decrease in albumin, you should look the anion gap will also decrease. So this should be corrected in whenever you are calculating the anion gap per se. So you check out this formula, how you do the corrected anion gap formula with the albumin. You check out the formula and you let me know in the group. So that this is the concept I am letting know. Just because normal anion gap, you should correct it for the albumin also, because for every 1 gram per deciliter decrease in albumin, there is 2.5 milliequivalent decrease in anion gap also. So sometimes though patient is having high anion gap metabolic acidosis, because there is decrease in albumin, patient is having, let's say albumin is 2 only, so anion gap will decrease by 5 milliequivalents. So let's say anion gap normally would have come 17 or something, but because of the decrease in albumin by 2, the patient will have an anion gap at 12 or something, which falsely interpreted as normal anion gap metabolic acidosis. So you should always correct the anion gap for albumin also, that is corrected anion gap. So you should always look at that also. What is the comment of the correct, what is the formula for correction of the corrected anion gap for the albumin? You let me know in the group. So these are the causes of high anion gap metabolic acidosis, that is diabetic ketoacidosis because increased generation of ketoacidosis, uremic acid because of the increased impaired excretion of the H plus ions or something, lactic acid because of the increased formation of lactic acid in the formula. There are different toxins. There is ethylene glycol poisoning, propylene glycol, methanol poisoning, ethanol poisoning, isopropyl alcohol. There are many causes of toxins which can cause high anion gap metabolic acidosis. These are the main causes of high anion gap metabolic acidosis. When you come into the normal anion gap metabolism, because of the chloride conservation in the kidney, because though there is a bicarbonate loss, so we have normal anion gap metabolic acidosis. Despite of the loss of bicarb, chloride is compensating it because of the conservation of chloride. Causes of Nagma is saline infusion or ureterosigmoidostomy or diarrhea, drugs like carbonic anhydrous imide, estazolamide. So though there is a loss of bicarbonate, there is conservation of chloride in the kidney. In the case of estazolamide poisoning, Addison's disease, all renal tubular acidosis, though there is a loss of bicarbonate, chloride is conserved. So normal anion gap metabolic acidosis is seen. In the case of total parental nutrition also you see Nagma. So these are the causes of Nagma. Though there is a bicarbonate loss, it is conserved with it is compensated with the conservation of chloride. So ureterosigmoidostomy, saline infusion, diarrhea, drugs, Addison's, renal tubular acidosis, total parental nutrition. Hagma, ketoacidosis, uremic acidosis, lactic acidosis and toxins. So these are the Nagma causes again: ureteric diversion, sigmoid fistula, excess of saline, diarrhea, carbonic anhydrous, Edison's, renal tubular acidosis, pancreatic fistulas and all. So how do you differentiate this? Let's say normal anion gap metabolic acidosis is there. How do you differentiate urinary anion gap? In the case of all causes of normal anion gap metabolic acidosis, it is generally urinary anion gap generally not used in the case of high anion gap metabolic acidosis. Generally, it is used in the case of NAGMA to differentiate between the, because most of the causes are renal or GI causes. So in them, you to differentiate between the renal and GI causes, you look at the urinary anion gap. So urinary anion gap is something between urine sodium plus urine potassium minus urine chloride. This is urinary anion gap. Normal urine anion gap is anywhere between 0 to 10. So generally anything more than 20 is considered positive. So this is urine sodium plus potassium minus chloride is a formula. You generally use it in the case of normal anion gap metabolic acidosis. So let's say its urinary anion gap is positive. That means there is renal tubular acidosis. So why do we use this formula per se urinary anion gap is that I'll explain it in the later slide, but I'll give you a brief introduction why urinary anion gap is used. What is the concept behind using the urinary anion gap? So urinary anion gap is used to tell whether ammonia is being excreted in the kidney or not. Generally, what is the concept is ammonia is generally excreted along with the chloride. So if ammonia is being excreted normally, so this difference is generally normal. So if ammonia is excreted low, if the ammonia excretion is not present, that is acid excretion, ammonia excretion is not there, the chloride excretion is also decreased. The difference will be positive in this. That is positive, more than 20 or something or anything positive in this. So if ammonia excretion is affected in the case of any renal tubular acidosis or anything in RTS per se, so the chloride also decrease, urinary chloride is also decreased. That's why it becomes positive. That is the concept behind using the urinary anion gap. So to check for the impaired ammonia excretion that is seen in the case of renal tubular acidosis, we are using this formula because it is a surrogate marker. Urine chloride is also excreted in the ammonia. That's why using the urinary chloride as a surrogate marker. So if there is anything positive, so urine ammonia excretion is decreased, chloride excretion also decreased, so that you'll get a positive urinary anion gap that is seen in the case of renal tubular acidosis. Then you check for the urine pH. Urine pH is more than 6, that is bicarbonate is more excreted, that is type 1 renal tubular acidosis. Anything less than 5.5, you check if the patient is hypokalemia, that is proximal renal tubular acidosis. If the patient is having hyperkalemia, that is type 4 RTA. So this is how you decay. If the patient is having urinary anion gap is low or negative, that is urine chloride is normal, urine ammonium excretion is normal, that means urine ammonium excretion is normal. It will become negative or normal, that is 0 to 0 or something, that will become negative. That is external, that is diarrhea or GI. That is the concept behind delta ratio. So delta ratio is to tell us what is the like for every change in anion gap whether the bicarbonate change is also equivalent or not. It will help us differentiate whether the NAGMA is present or HAGMA is present or there is a mixed metabolic acidosis, metabolic calculus. How is it telling? As I already told you, in the case of NAGMA, for every loss in bicarbonate, it is compensated by chloride preservation. So in the case of NAGMA, I will give an example. Let's say anion gap is 10. 10 minus 12 is around 2. And that is 2 is the change in anion gap, and let's say bicarb is around 16. 24 minus 16 is around 2 by 8. 24 minus 16 is 8. Anything 2 by 8 is 1 by 4. It is 0.2. So here anion gap didn't change much. It is normal anion actually. Normal anion gap 10 to 12 is normal actually in them, but the bicarbonate is significantly decreased. Whatever decrease in bicarbonate is compensated by chloride. That is why normal anion gap is seen. So in that the ratio is less than 0.4 in such cases. So that is why the calculation of delta ratio is very important to differentiate the NAGMA and HAGMA. I'll also tell you the one more example. Let's say the anion gap is 20 or something, but bicarbonate is also 16 or something. 20 minus 12 is 8. 24 minus bicarbonate is 16 is also 8. So in them the ratio is 1. In them the clearly high anion gap metabolic acidosis is there, in which the whatever bicarbonate decrease, it is not compensated by chloride. That is why anion gap is also increased. So in that the ratio is 1. So anywhere, any ratio less than 0.8, 0.4 is definitely NAGMA. 0.4 to 0.8 is a mixture of NAGMA and HAGMA. Anything between 0.8 to 2, it is a pure HAGMA where there is no compensation of chloride with chloride. There is pure the bicarbonate is decreased, and then there is high anion gap. And let's say the anion gap is around 20, and 20 minus 12 is 8, and bicarbonate is only 22. So 24 minus 22 is around 2. So 8 by 2 is around 1 by 4, it is 4. So the bicarbonate did not decrease significantly, but the anion gap is significantly elevated. So there are some other causes of anions that is causing the acidosis per se, some acid producing, some lactic acid, some organic anions. Some other thing is causing the anions that is not causing significant bicarbonate decrease. So here there might be a mixture of Hagma plus metabolic alkalosis per se. So anything ratio more than or equal to 2, there is mixed Hagma plus metabolic alkalosis. So what is the use of delta ratio is to differentiate between Nagma, Hagma, if there is a mixture of Hagma plus metabolic acids. Anything less than 0.4 there is a pure Nagma because of the compensation of chloride, though there is no shift in anion gap, there is no shift in anion gap, but there is a change in bicarbonate. Anything 0.8 to 2 is generally anything 1 to 2 or something. Hagma is the thing where there is no compensation of chloride with bicarbonate. So for every change in bicarbonate, the anion gap also will change in the similar way. Let's say bicarbonate changes 8, delta also changes, anion gap also changes 8 or something. So the ratio is generally 1. So in that case, the Hagma is here where there is no compensation. But let's say the anion gap is more, so there is definitely acidosis. There is high anion gap metabolic acid. But bicarbonate did not change. The bicarbonate is only 22. There is only 2 changes, but the anion gap is very more. So in that there is a mixture of high anion gap metabolic acid with metabolic alkalosis. Since there is no change in bicarbonate, so this is the ratio that is helpful in differentiating Nagma, Hagma, and mixed changes of Hagma plus metabolic alkalosis. So this is the delta gap. In the other ways, you can use the Na plus minus Cl minus 36 to change. Anything less than minus 6 is mixed high anion gap normal anion gap metabolic acidosis. Anything between minus 6 to 6 is only high anion gap metabolic acidosis. Anything plus 6 is mixed high anion gap metabolic acidosis plus metabolic alkalosis. This is one more formula that can be used. Na plus minus Cl minus 36. Based on these values, anything less than minus 6 or minus 6 to 6 or more than 6 where high anionic metabolic Hagma plus metabolic alkalosis. This is one more thing that can be used to diagnose. So this is the RTS we discussed already in the previous hypokalemia session. One more recollection. So there is one more parameter where it's called osmolar gap, serum osmolar gap. What is the use of serum osmolar gap? Where there is measured osmolarity versus calculated osmolarity. So we generally use as calculating osmolarity, we use sodium, blood urea, nitrogen plus glucose to calculate the serum osmolarity. So measured is something we measured in the laboratory. So generally difference is generally only less than 6 or something. If anything more than 10 is there, so there is some other osmolars other than sodium, blood urea, nitrogen and glucose that is causing the increase in osmolar gap. So in the case of toxicities, especially methanol poison, especially ethylene glycol, propylethyl glycol or isopropyl alcohol, in them there is this cause increase the osmolarity because of their electrolytes, the ions itself are higher osmolarity, they constitute some osmolarity in the serum. So that is why measured and serum calculated osmolarity are different, because in the calculated osmolarity we are using only sodium, blood urea, nitrogen and glucose, we are not including these toxins. That is why difference will come more than 10. So that is how you need to keep this also in mind when you are checking the osmolar gap, especially this ethylene glycol poisoning, propylene glycol poisoning, isopropyl alcohol poisoning, where they have higher osmolarity, they can cause the increase in serum, increase in measured osmolarity, where we are not in the case of calculated osmolarity we are not including this toxin osmolarity, where we are using only calculated osmolarity, we are only using sodium, glucose and blood urea, nitrogen. Measured osmolarity will be a little on the higher side, that is more than 10 difference will be there. In that cases you should always suspect the poisoning. How do you approach the clinical approach? So we all discussed about what is the normal value of pH, how do you interpret in the case of what is the less than 7.35 is acidotic, more than 7.45 is alkalosis. Even in the case of normal pH, you should always look at bicarbonate and PCO2 where there might be compensated state less than 7 point. In that cases, in the compensated state, if the less than 7.4 it is acidosis is the primary pathology, it might be compensated metabolic acidosis with respiratory alkalosis or something. If it is more than 7.4, alkalosis is the primary pathology. That might be primary pathology, maybe respiratory metabolic, where it might be compensated with other vice versa thing. So this is how then you look at the anion gap, whether Nagma or Hagma. Nagma is generally due to the chloride conservation, that is why anion gap is normal. And in them you should always check for the corrected anion gap with the albumin, where for every 1 gram decrease in albumin there is 2.5 milliequivalents decrease in anion gap. Also sometimes we falsely interpret high anion gap metabolic acid as normal anion gap in the case of hypoalbuminic patients. Then you looked at what are the causes of Nagma and Hagma. Hagma is generally decay, lactic acidosis, toxins and any uremic causes. Nagma is generally renal RTS and GI causes. any diarrhea or something. Then you looked at in the case of NAGMA, I told you should look at the urine anion gap per se. In the urine anion gap, you check at Na plus K plus minus Cl minus. So if it is generally positive, why we are doing this? Because urine chloride is a surrogate marker of urine ammonia excretion. So in the case of RTA, urine ammonia excretion is decreased. That's why urine chloride is also decreased. That is why urine anion gap, which is Na plus K plus minus Cl minus, because Cl minus is decreased, it becomes positive in the case of RTA, whereas urine anion gap is generally negative in the case of GI cause, extrarenal causes. So then you looked at the delta ratio to look at whether to differentiate between the NAGMA, HAGMA is a mixed HAGMA plus metabolic alkalosis. In the case of delta ratio is any change in anion gap divided by bicarbonate change. In the case of delta ratio, if the anion gap change is not much there, bicarbonate change is significant, general ratio will generally come less than 0.4, that is NAGMA. Anything between 1 to 2 or 0.2, where the change in anion gap is corresponding with the change in the bicarbonate, because it is not compensated by chloride preservation, that is HAGMA, that is the ratio will be almost be similar. If the change is like anion gap is significantly changed, but bicarbonate change is not significant, the ratio will become more than 2. That is, let's say anion gap is 20, the change is more about 8 or something. But bicarbonate change is only 22 is bicarbonate, change is only 2. In that the ratio is more than or equal to. In that there is a mixed HAGMA plus metabolic alkalosis is there. The cause of HAGMA will be 100 other things where the lactic acid or some toxin is causing, but there is also underlying metabolic alkalosis is also there. So there is a mixed pattern of both. So this is again, check the pH if it is acidosis or alkalosis, look at the bicarbonate and PCO2, what is the main abnormality, match it in also look for the compensation. So in the case of acidosis, in the case of metabolic acidosis, I told you 1.25 is a compensation, 1.25 is compensation. In the case of metabolic alkalosis, I told you 0.75 is a compensation. In the case of acute respiratory acidosis, for every 10 change in the PCO2, there is a one change in the bicarbonate. In the case of alkalosis, in acute respiratory alkalosis, for every 10 change, the change is 2. In the case of any chronic respiratory alkalosis or acidosis, for every 10 change in the PCO2, the change is 4. So that is how you look for the proper compensation is there. If proper compensation is there, generally pH will be 7.35 to 7.4 family. But then you change based on less than 7.4 or more than 7.4, you change the primary pathology. What is the primary pathology? So then you determine the compensation is present or not. Then metabolic acid based on the anion gap, HAGMA or NAGMA is present. If HAGMA is present, determine the ratio. Then if delta ratio is, determine the delta ratio. Sorry, the printing mistake is delta ratio. If more than 2 is there, the associated metabolic alkalosis is present. If less than 1 is there, it is generally NAGMA is there. 1 to 2 is generally HAGMA. So anything less than 1 in the delta ratio is NAGMA. Less than 0.5 is definitely NAGMA. 0.4 to 1 is generally mixed pattern. But anything less than 1, you take it as NAGMA. 1 to 2 is HAGMA. More than 2 is a mixed HAGMA plus metabolic alkalosis. So if NAGMA, generally go for urine anion gap, it is positive, is distal RTR, chronic respiratory, distal RTR is generally RTR, some chronic respiratory alkalosis because, but generally RTA is what we consider mostly. Then negative, any external cause, diarrhea or something else is the cause, but generally negative is external loss. So these are the various causes. What is the cause of increased unmeasured anions? This is the cause of increased anion gap, that is uremic acidosis, ketoacidosis, lactic acidosis, small bowel resection, methanol, ethylene glycol, aspirin, acetaminophen, toluene. These are all increased the anion gap. What is the cause of increase in anion gap? These are the ions that are responsible. In the case of uremic acid, sulfate and phosphate and urate. In the case of ketoacidosis, that is estrogen and beta hydroxybutyrate. L-lactic acidosis and D-lactic. I'll again discuss what is the importance of this. Ethylene glycol, glycolate and all. Polyglutamate in the case of acetaminophen. These are the causes of normal anion gap metabolic case. Most of them in NAGMA, the loss in bicarbonate is compensated by the conservation of chloride. Diarrhea, loss of bicarbonate, uterus, loss of bicarbonate. In proximal, most of them are due to the loss of bicarbonate. In the case of distal RTA type 4, where the hyperkalemia is due to the impaired acid secretion per se. So these are the various causes. So these are the causes of NAGMA. This is the exception. In the case of cholestyramine, where the release of, where the, in the case of where the generally the bicarbonate is compensated with the chloride preservation. In this case, the loss of chloride is compensated by increase in bicarbonate. So there is NAGMA per se. So changes in chloride and bicarbonate are compensated. So this is one exception. So this is the dilution is one of the exception also. So that is this is the case where the HAGMA is this. These are the ions that are responsible for anion gap. These are the ions responsible for NAGMA. So these are the things. These are I already mentioned this osmolarity. Osmolar gap, where the measured and calculated osmolarity might be different in the case of few poisonings, especially ethanol, methanol poisoning, ethylene glycol poisoning, propylene glycol, isopropanol, salicylate does not cause much significant. These high osmolarity, especially these top 5, these are the causes of high osmolar gap, where the measured osmolarity and serum osmolarity, where we calculated with sodium, blood urine hydrolyzed glucose, the difference is more than 10, which we cause high osmolar gap. So especially these 4 poisoning, ethanol poisoning, methanol poisoning, ethylene glycol poisoning, propylene glycol poisoning, isopropanol, these are how significant change in the osmolar gap. So these are important. Generally calculated more than 10 is significant. So urine anion gap, I already mentioned this side, the indirect mixture of urine ammonium. This is why we generally use for the only for the norma, we generally don't use for the high anion gap metabolic acidosis. So this is one more thing. So sodium ammonia excretion accounts for 50% of urine osmolarity. So anything more than 75 milliequivalents per deciliter is also indicates the appropriate excretion of ammonium per se. So this can also be used for the whether the ammonium is being excreted properly from the kidney, that whether the renal is not on. We use the urine anion gap also as a surrogate. You're using urine chloride as a surrogate marker. I already mentioned. If it is positive, the ammonia is not being excreted in the properly. That is why urine anion gap is increasing. This is the one more parameter where you use urine osmolarity. If it is more than 75 milliequivalents per liter, this is because more than 75 is present, because ammonia is the major parameter that is constituting for the urine osmolarity. If it is more than 75, that means ammonia is being excreted properly. That doesn't mean that is the renal kidney is functioning not well. You should look for the extrarenal causes. If it is less than 25, ammonia is not being excreted properly. That is why urine osmolarity is decreased. So that is why the renal is the cause. Renal excretion of acid is the problem. That might be RT or something. So both urine anion gap, urine osmolarity should be always used in the especially in the case of NAGMA, whether it is renal or extrarenal. So urine anion gap is generally positive in the case of renal causes. That is the same way urine osmolarity is generally decreased in the case of because urine ammonium excretion is decreased, urine osmolarity is also decreased in the case of tubular defects. So urine anion gap is generally negative or normal in the case of extrarenal causes. Urine osmolarity is generally normal in the case of extrarenal cause, because urine ammonia excretion is normal, more than 75 in the case of extrarenal causes, because renal function is normal. So delta ratio already mentioned. Generally diarrhea, I'll give an example. In the case of diarrhea with shock, where the ratio is generally 1 less than 1, because the diarrhea is a NAGMA thing, normal anion gap metabolic acidosis. So in them the ratio is generally less than 1 because of NAGMA. In the case of higher anion gap, I already mentioned more than 2 is the cause. In the case of pure lactic acidosis, some amount of lactase is generally not buffered by it is something. So ratio is something around 1.11 to 2. It is also HAGMA. It comes in 1 to 1. Diarrhea is one example where NAGMA is the ratio is less than 1. So uremic acidosis, this is initially the NAGMA is seen, generally converts into HAGMA in the later stages. So that is one more thing, because of the impaired ability to excrete H+. So I already mentioned the pathophysiology behind the HAGMA is the impaired H+ excretion or any acid excretion per se. So what is the use of bicarbonate in the case of CKD patient? So what is the role of bicarbonate? So what they gave in the guidelines of KDIGO is, we suggest that in people with CKD and serum bicarbonate, that is in patient with CKD and serum bicarbonate less than 22 millimoles per liter, treatment with oral bicarbonate be given to maintain serum bicarbonate within normal limits unless contraindicated. So anything less than 22 only you should give in the case of CKD patient, so that it will prevent the progression of CKD, because acidosis itself worsen the CKD and it will increase in the progression of CKD. It will also has bone resorption. So to prevent all these bone related problems and also prevent the progression of CKD, any bicarbonate less than 22, we supplement the bicarbonate to maintain the normal bicarbonate level. So this is the KDIGO guidelines. So in distal RTA you have NAGMA. These are different scenarios. Distal RTA, NAGMA, high positive urine anion gap, hypokalemia will be there. Urine pH will be less than 5.5, generally associated with stones. You look at the hypokalemia, you will understand. So intact proximal tubular function. These are all the different causes. I don't want you to remember all these causes. So generally the treatment in the case of distal RTA is 1.3 milliequivalents, 1 to 3 milliequivalents of bicarbonate, that is per kg. Let's say it's a 60 to 60 kg, around 60 to 180 milliequivalents you start. In general, correct serum bicarbonate alone. Potassium correction can also be given. So generally you correct the potassium first, then you give the bicarbonate later, because if you give bicarbonate per se, bicarbonate can itself worsen the hypokalemia because of the intracellular list, or it can causes caluria, loss of potassium in the urine. So first you correct the potassium. In any case, like let's say both the patient have metabolic acidosis with hypokalemia, first correct the potassium first. because if you give bicarb per se before correcting the potassium, then the bicarb, whatever bicarb you give, it will worsen the hypokalemia more, because it causes potassium loss in the urine. It will also cause intracellular shift of the potassium into intracellular shift, that will worsen that. So generally you correct the potassium first, then you correct the bicarb. Proximal RTA also, because of the generally proximal RTA is due to the, because most of the bicarb which is filtered is absorbed in the bicarb. So what happens is more than around 4,320 milligrammes of bicarb is generally filtered daily. Most of it is absorbed in the proximal RTA. So whatever loss, because proximal RTA it cannot be absorbed there. So whatever is lost generally compensated and is conserved, it is absorbed in the distal levels. So generally much of the bicarbonate, much of the severe acidosis is not there. So with the ongoing loss also, there is a reduced filtration of bicarbonate from the GFR, from the capillaries also. That's why there is a decreased loss. So that's why whatever bicarbonate that is lost in the proximal, it is generally absorbed at the distal level. That is why in the case of proximal there is no significant acidosis per se, because proximally it is compensated at distal level. It is also decreased filtration of bicarbonate from the at the glomerulus level also. That is why in the proximal artery there is no significant acidosis. That is why though the bicarbonate loss is there at the proximal level, generally at the distal level the bicarbonate pH is generally less than 5. Urine pH generally becomes less than 5.5, because whatever bicarbonate loss at the proximal is generally absorbed at the distal level, and it is also decreased filtration of bicarbonate also. So this is one thing about proximal RTA. Generally in the case of proximal RTA, you generally correct the potassium first, because it requires high amount of bicarbonate to generally preserve it. Generally you only give potassium per se. So the type 4 RTA is where the hyperkalemia with acidosis is seen. It is generally seen in the case of diabetes when they are given some drugs like NSAIDs or calcium inhibitors or heparin, or in case of some CGDs or Addison's disease. In this hyperkalemia is there. Hyperkalemia with metabolic acidosis where urine pH is less than 5.5 is generally seen mostly in the diabetic. When I'll give an example. When a diabetic patient is started NSAID, some endomethacin or some naproxen or something, they generally develop acidosis. So and hyperkalemia. So if a diabetic patient after starting NSAID or something, he is developing metabolic acidosis with hyperkalemia, first thing you should suspect a type 4 RTA. What is the cause of type 4 and type 1 and type 2 RTA? I'll discuss when I am discussing nephrology, what is the pathophysiology behind it. Now I am going most in the case of what is the type 4 RTA in a brief. Diarrhea, there we already discussed in the diarrhea topic what is osmotic, what is secretory. In osmotic diarrhea, there is more loss of water when compared to electrolytes. In secretory diarrhea, there is more loss of electrolytes. There is bicarbonate is lost more. So whatever loss in the osmotic diarrhea, there is only minute loss of bicarbonate, most of it is water. So whatever loss of bicarbonate is there, it is generally compensated at the renal. At renal level, it is generally conserved. And hypokalemia in the diarrhea is mostly due to the, generally because of the diarrhea there is volume loss, in that there is an increase in aldosterone per se. Because of aldosterone there is a potassium loss. Any increase in aldosterone conserves sodium and loss in potassium. So that is one more mechanism in diarrhea, how it is causing the hypokalemia. One is loss of electrolytes in the diarrhea per se, then one more mechanism because of the increase in aldosterone because of the decreased volume. So acid-base uncomplicated diarrhea, generally we have hyperchloremic metabolic acidosis, because there is loss of I mentioned NOGMA, hyperchloremia is there, hyperchloremic metabolic acidosis is there, and negative urine anion gap is here. Generally positive is in distal RTA. And diarrhea with hypovolemia because of the decreased perfusion, hyperchloremic metabolic acidosis, lactic acidosis can be a cause. Diarrhea plus vomiting, there is a mixed thing, hyperchloremic metabolic acidosis plus metabolic alkalosis, because in the case of vomiting what will happen is because of the excessive acid secretion, there is hypokalemic, hypochloremic, metabolic acidosis with metabolic alkalosis because of the acid loss. It's a paradoxic aciduria is the classical things that is commonly seen in gastric outlet obstruction. Generally it is hypochloremia with metabolic alkalosis in the vomiting. That is why if the patient has both diarrhea and vomitings, they have mixed metabolic acidosis and alkalosis pattern. So hyperchloremic metabolic acidosis, metabolic alkalosis pattern is generally seen. So this is the thing that you need to remember. So in the case of hypovolemia, the hyperchloremic metabolic is lactic acidosis because of hypovolemia there is a decreased perfusion. So hyperchloremia is because whatever loss is in bicarb is there, that is compared to the chloride, that is why normal anion gap is seen. So this is how, this is again the mechanism why the hyperchloremia is there and lactic acidosis is there. So in the case of any mild thing, you can just give ORS. In the case of moderate to severe, you replace with volume and normal saline intravenously. First you collect the hypokalemia prior to any bicarbonate diffusion. Bicarbonate diffusion will cause IV and calories as already mentioned. In selected cases, you can give bicarbonate if significant acidosis, that is pH less than 7.1 is there. You can definitely give bicarbonate therapy to prevent any metabolic and hemodynamic compromise and to prevent the respiratory compromise and hemodynamic. Because if there is a metabolic acidosis per se, it will compensate by the respiratory alkalosis. So patient will be severely taking, he will go into respiratory muscle fatigue. So that is why before if the patient has severe metabolic acidosis, any pH less than 7.1 or something, you give small amount of bicarbonate so that patient won't go into respiratory fatigue or something. So these are the cause of high and gap metabolic acidosis I already mentioned. So lactic acidosis, coming into lactic acidosis, this is the pathway behind the lactic acidosis. So pyruvate plus Na plus DH plus NADH plus used to lactate plus NAD plus. So this ratio of NADH plus NAD plus determines what side it should go. This pathway should go what pathway. So if the ratio is NADH is predominant, it will convert to this pathway. NAD plus is generated. If NAD plus is the predominant, it will convert to NADH. So this is the main predominant pathway determines the direction of the reaction. So if NADH is more, it will convert to NAD plus. If NAD plus is more, it will convert to NADH. So that is the major pathway that will determine this is the bidirectional reaction. So generally type A and type B, there are two kinds of lactic acid, type A and type B. Type A is due to the tissue, the decreased supply, decreased perfusion per se. Type B is due to the multiple, it can be due to drug related problems, some systemic abnormality that is causing type B. I'll discuss later what is the cause of type A and type B. But there are various causes of type A and type B. So type A is due to the decreased hypoxia, decreased perfusion supply. Type B is due to the bicarbonate, that is due to toxin or systemic diseases. So this is the cause of type B. There are the various drugs that can cause type B because the patient won't be in shock or there is no decreased tissue perfusion per se. But patient will still have lactic acidosis. That might be due to the impaired reaction of this. Let's say I will give an example. Metformin. Metformin, there is increased NADH generation per se. Because of the increased NADH generation, this reaction will shift towards generation of lactate and NAD plus. So that is the reason why lactates are, there is lactic acidosis per se. So this is type B lactic acid. This is not due to the decreased tissue perfusion or something. This is due to the some drug related or systemic abnormality. So these are the few drugs where they cause increase in NADH, that is metformin, ethanol, and in case of ethanol, it depletes NAD plus. That is why NAD plus needs to be generated. So the increase in NADH, that will increase the reaction towards lactate and NAD plus generation. So these are the various drugs. Though there is no decrease in tissue perfusion, because the type B lactic acidosis, these cause this change the NAD plus NADH to NAD plus ratio. That is how they shift the reaction to generation of lactate. That is the common examples of metformin, ethanol, methanol, ethylene glycol, propylene glycol, salicylate poisoning, cyanide poisoning, some catecholamines, and antiretroviral, like especially NRTs. So they can cause type B lactic acidosis. These all drugs should need to be remembered when you're looking at the lactic acidosis per se. So when there is a lactic acidosis, when the patient is not in shock, these all drugs needs to be remembered because these can cause lactic acidosis by shifting the ratio of NADH to NAD ratio. That is how shifting reaction toward generation of lactates. The main examples: metformin, ethanol, methanol, ethylene glycol, propylene glycol, cyanides, and salicylate poisoning, antiretroviral drugs. These all can cause lactic acidosis. This is like type B lactic acidosis. So again, coming to the type 1 is due to the impaired oxygen delivery, that is to hypertension or hypovolemia, some shock, severe anemia can cause type A lactic acidosis, any arrest, any cardiac arrest or hypoxemia per se, and compartment that can contain the decreased perfusion, increased oxygen demand also, any hypothermia or any fever or any increased workload of breathing. These are all type A. There is a demand mismatch. So there is a decreased supply per se or increased demand per se. These are all due to the impaired oxygen delivery. So whether we are not able to provide proper oxygen, or the patient is requiring higher amount of oxygen. These are all type A lactic acidosis. This type B lactic acidosis is mainly due to the impairment of NADH to NAD ratio or some metabolic cause, not due to the impaired oxygen delivery or increased requirement or decreased supply of oxygen. So these are all, I already mentioned the cause. Propofol is one more, valproic acid, linezolid can cause, HIV antihistaminophene, ethanol, these are sodium nitroprusside. You can remember this valproic acid, metformin is one more important thing, sodium nitroprusside is one more thing, all alcohol related poisonings are one more thing you can remember, antiretroviral, especially NRTs. Though we are not using NRTs right now, so they are also important. All impaired clearance also. So if the lactates are not improperly cleared, general lactates are generally converted to bicarbonate in the liver. So if there is liver failure or chronic liver failure, chronic renal failure also, any mitochondrial dysfunction where the lactate is converted to bicarbonate. So if there is impaired renal failure also, this can also cause increase in lactates. So this is a type B lactic utilization. This is due to the impaired oxygen utilization per se. This is due to the decreased oxygen delivery, increased oxygen delivery. This is impaired oxygen delivery per se. So this is one more thing. So these are all coming under the these are all causes L-lactic acidosis. So though two different kinds of lactic acidosis are there, L-lactic acidosis and D-lactate. So L-lactate is based on the presentation of OH ion, whether it is like that biochemical where D and L forms, where the change based on the OH, whether on the right side or left side you tell it del E and L-lactate. Generally in our body most of them are L-lactates. So delactates are generally not generated in our body, human body per se. They are generally generated by the bacteria in the colon or gut per se. So delactate is generally not measured in our lab parameters. Whatever you are doing in the routine lab parameters, it generally detects only L-lactate. That generally doesn't detect the delactate. So generally, as in the case of few the patient, let's say the patient went gastric bypass or some colon resection done, surgery is done, in the patient who is having short bowel syndrome or something, in those patients the patient will have delactic acidosis because of the any pancreatitis patient where the carbohydrate is not digested properly. In them the bacteria will convert the whatever carbohydrate that is there, that will convert into delactate. So they will have delactic acidosis. These delactate is generally not detected in the normal routine blood test, but the patient will have acidosis. The pH will be 7.2 and bicarb might be slightly decreased 16 or something, but lactates are normal. We don't know what is the cause of acidosis per se. That might be a case of delactic acidosis where there is a patient underwent gastric bypass, some intestinal resection is done. In some cases DK patients also will have DK and delactic acidosis. Some propylene glycol poisoning patients also will have delactic. So what you need to remember is these patients who underwent gastric bypass and intestinal resection, some DK, some patients of DK, they have some delactate. So some unexplained cause of diabetic ketoacidosis may be explained by this lead lactic acidosis. I already mentioned the DK class. Some case of DK might be due to starvational ketoacidosis where we are not feeding properly despite of DK being resolved. One more cause is D-lactic acidosis where pH will be 7.2 or something, bicarbonate is around 17 or something, lactates will be normal because D-lactate is not generally detected. That might be a cause. D-lactic acidosis is generally seen in this case, such cases. So we generally often treatment of underlying cause, whatever the cause is generally enough in this case. If pH is less than 7.5, you can give bicarbonate. So how much bicarbonate is generally required? So generally you don't correct the bicarbonate to normal level in the case of lactic acidosis. So let's say pH is less than 7. Bicarbonate is 8 or something. You generally correct it to 15 or something to make it more than 7.1 or 7.2 something. That is it. The target is not to normalize the pH normal sometimes because because too much alkali can also depress the cardiac function, and alkali may activate the phosphoprotectic kinase activates pathway and increase the lactate production again. So that is why you should not give too much alkali also because it suppresses the cardiac function and all. So the target is always bicarbonate. You bring the bicarbonate to 15. So what is the formula behind this? You generally give 0.5 into body weight. The target, let's say our target is 15, our bicarb is minus 12, 8 or something. It is 7. Let's say body weight is 60. 0.5 into 60 into 7. 30 into 7 is around 210. 210 milliequivalent is generally what we give over next 24 to 48 hours or something. That is what you give. So initially you give 100 milliequivalents in the first 6 hours. Next 16 hours you can give the remaining thing. First 8 hours you give half. Next 16 hours you can give the remaining thing. And bicarbonate is generally given slowly. So that is it. In the case of lactic acid, generally don't normalize to. If pH is less than 7.1 only, you generally give bicarb because it can cause hemodynamic compress and respiratory fatigue. Generally you don't normalize the bicarb to normal 7.35 or 7. You generally bring it around 7.25 or something because if you give excessive alkali also it suppresses the cardiac function and all. So that is why you correct it around 15, bicarb to 15. So 0.5 into body weight to targeted bicarbonate minus actual bicarb which is present. You correct it as per that formula. The other things therapy hemodialysis can be done. This one more thing, trihydroxymethyl aminomethane, this can also be used because this can also be used in the case there is other metabolites or tribunate. These are all research purposes. We generally don't have availability in our setups. So the next poisoning, methanol poisoning. We have seen methanol, which is common coloring agent we use in the spirit or something. It is in antifreeze, dyes, varnishes, cheap alcohols also. In diesel also they will mix some amount of methanol something. So generally the toxic metabolites are generally formic acid and formaldehyde. The generally T half is 14 to 24. They have already the case visual impairment. They come with blindness or confusion, nausea, vomiting, abdominal pain, and pancreatitis. Generally these have high osmolarity. So generally pH will be bicarb will be less than 20 and generally based on bicarb we can tell bicarb less than 20, 10% mortality, bicarb less than 10, 50% mortality. This is a classical case of bicarb. Plasma methanol will be more than plasma methanol poison. Plasma methanol will be more than 20 and documented generally osmolar gap. I mentioned few: ethanol, isopropyl alcohol, propylene glycol, methanol, salicylate will have high osmolar gap more than 10. So suspected methanol injection, any suspect methanol injection, osmolar gap more than 10 or bicarb less than 20, pH less than. We have 3 or 4 treatment options. One is folinic acid we give to conserve, then oral folate can be used. It enables the conversion of formic acid, which is a toxic metabolite, to CO2 and H2O. folinic acid can be given. Femiprazole, which is alcohol, which is formic acid, is generally derived from the alcohol dehydrogenase pathway. So femiprazole can be given, and also ethanol can also be given. Ethanol has a higher capacity in binding to alcohol dehydrogenase compared to methanol. So ethanol can also be used if femiprazole is not available. So IV folinic acid, ethanol can be used, femiprazole can be used. So if still not available, you can go for hemodialysis, also an option in the case of methanol poisoning. If in ethanol treated patient, if methanol is more than 50 or renal dysfunction is there, visual impairment is there, severe acidosis is there, in those cases you can go for hemodialysis per se. So these are the indication. In methanol poisoning, you can try folinic acid, you can try ethanol, you can try femiprazole also. So next, propylene glycol, which is generally seen in the case of diluent in the case of oral and IV drugs, especially phenytoin, diazepam, lorazepam, phenobarbital, nitroglycerin. These are all common drugs we use in our diet. Phenytoin, diazepam we use, lorazepam we use, phenobarbital use. Generally toxicity occurs at very high levels, 100 milligrams, like patient who are on chronic infusions or something. So generally they have CNS and cardiac patient like nystagmus, ataxia, disorientation and all. They can have agma both due to the D and L-lactic. Generally the most D and L-lactic acidosis, and treatment is generally discontinue the drug infusion and generally hemodialysis in the case of significant cases. Ethylene glycol, which is seen in the case of antifreeze, like that is normally used in the case of cars where they are in the cold winters or something. So generally in the case of Western countries is more common. Usually oral injections, the toxic metabolites are glycolic acid and all. They generally have severe CNS and myocardial and pulmonary. They are very rare in India. These poisoning generally you don't see. Methanol is one common you see. These propylene glycol and ethylene glycol are generally rare. That is why I didn't mention the case scenarios per se. Generally I mentioned for theory purposes I am mentioning. So they can have oxalate stones also. This ethylene glycol, and I have seen one case report in NEGM where a 7-year-old boy who is having PEG injection, polyethylene glycol injection, he developed with nephrocalcinosis because of the calcium oxalate stones, and have metabolic acidosis also. That is due to ethylene glycol, similar pathway. So this is that is one more thing. They can cause oxalic acid. That is oxalic acid can cause calcium oxalate crystals also. So the treatment is mentally supportive care. You can give sodium bicarbonate, can be given pH less than 7.2. You can give a pyridoxine ethanol, can also alcoholic. Femiprazole can be tried. Ethanol can be tried. Hemodialysis. The same for all alcoholic alcohol poisonings. The same thing can be given. So aspirin or salicylate. So aspirin and salicylate is one notorious drug which can cause both respiratory alkalosis and metabolic acidosis. How it causes, I will tell you. So what it causes is it causes uncoupling of oxidative phosphorylation. So it inhibits the Krebs cycle and increases the lipolysis and ketone body formation. That is how it causes ketoacidosis per se, because one uncoupling oxidative phosphorylation causes lactic acidosis. It also causes the lipolysis and ketone body. That is how metabolic acidosis causes. But initially it stimulates the medullary center of respiratory. That is how it causes it stimulates the respiratory center more and causes respiratory alkalosis. So initially the pattern of after salicylate poisoning, it stimulates the respiratory and causes respiratory alkalosis. Later after the inhibition of oxidative phosphorylation and inhibiting the Krebs cycle, it causes metabolic acidosis. So it have both respiratory alkalosis and metabolic acidosis. So acute poisoning mainly nausea, vomiting, abdominal pain, tachypnea, tinnitus, deafness, and confusion and coma. Chronic poisoning, it can have less GI symptoms per se and more of neurological symptoms are more prominent. That is one more thing that I'll mention. In acute poisoning, you'll have more of GI symptoms. In chronic poisoning, more of neurological symptoms are. One thing I'll need to remember, both initially respiratory alkalosis, later metabolic acidosis is seen. So first thing is you give charcoal to reduce the GI absorption. You give sodium bicarbonate to alkalize the urine to promote the more excretion of salicylate. And if you can try hemodialysis also. So main treatment are charcoal, and you give bicarbonate, alkalize the urine to suppress the. What are all the cases you can alkalize the urine? In case of rhabdomyolysis also, I cause the alkalization of urine so that you can excrete the more myoglobin. So this is salicylate poisoning is one more thing. You mention what are the other places where you alkalize the urine with bicarbonate so that you can excrete the more amount of the toxin whichever is there. So you can try hemodialysis also in this case. So coming into that approach, if there is low bicarbonate, check ABG to exclude any chronic or respiratory alkalosis which is causing the compensatory metabolic acidosis. Then calculate the anion gap. If it is normal anion gap, these are the causes. Check the urine anion gap. If urine anion gap is positive, you look for RTS mainly. And mainly RTS are the cause. If urine anion gap is negative, you can check for urine osmolarity also. If urine osmolarity is more than 75, that the kidney is functioning normally only. Then that means extrarenal cause. If urine osmolarity is low, that is ammonia is not secreted properly, that is renal cause. So urine anion gap is negative, so that is diarrhea, constipation or any extrarenal cause per se. So if the anion gap is increased, you look for high anion gap metabolic acidosis where the cause is renal origin, that is uremic acidosis, EGFR especially. Generally initial cause of EGFR more than 15 to 20, general normal anion gap metabolic acidosis is there. If end stage renal disease, you find HAGMA. So external cause lactic acidosis, diabetic ketoacidosis, starvational ketoacidosis, alcoholic ketoacidosis, poisoning like ethylene glycol, propylene glycol, These are all the causes of high anion gap metabolic acidosis. So these are the causes. So now we go into case-based scenarios. We'll discuss how the case-based. So I hope you understood everything about the metabolic acidosis. How do you interpret? What are all the causes you can think? So I'll again summarize. You look at the pH less than 7.2 phase acidosis, more than 7.3 phase alkalosis, 7.45 is alkalosis, 7.35 and 7.45. So you take a mean of 7.4. In the case of compensated, maybe sometimes the normal pH will be there, but bicarb will be low. In that side, what side of 7.4 it is there is more important. If it is less than 7. Acidosis is the primary pathology. More than 7.4, alkalosis is the primary pathology. Then you look at what is the cause of acidosis, whether metabolic or respiratory based on PCO2 and bicarb. Then you look for the compensation. I already told you about the compensation formula. Then you look at the anion gap, whether the high anion gap or normal anion gap. High anion gap, I already mentioned the causes like lactic acidosis, diabetic ketoacidosis, toxins, and normal anion gap mainly RTS and GI losses. So why the normal anion gap acidosis is there? Because of the chloride conservation, because of whatever bicarbonate is is conserved at the chloride levels. So that is why normal anion gap is seen. So if normal anion gap is calculated, you divide into HAGMA and NAGMA. Before doing this, you check for albumin level also. You correct the albumin for anion gap. For every 1 milligram decrease in the albumin, there is 2.5 milliequivalent decrease in the anion gap. So that before interpreting it, you check for the albumin levels also. Then you calculate the urine anion gap for the normal NAGMA patients. So urine anion gap is positive. That means ammonia is not secreted properly, chloride is low, that is why urine anion gap is positive. That means there is RTA cause. So based on RTA, you check urine pH, you check. If urine pH is less than more than 5.5, that is significant bicarbonate loss, that is distal RTA. If urine pH is less than 5.5, that is no significant bicarbonate loss is there, that is acidotic urinol is being secreted. Then you check for hypokalemia is there, that is proximal RTA. If hyperkalemia is there, type 4 RTA is there. So if urine gap is negative or normal, you check for GI losses. Then you check for delta ratio, whether it is NAGMA, HAGMA or metabolic alkalosis. Because for every corresponding change in anion gap, there should be a significant change in bicarbonate also. Let's say anion gap is changing by 8, bicarbonate is also changing by 8. That means the ratio will come to 1. That means there is no compensation with chloride. That is HAGMA. There is no compensation with chloride. If bicarbonate loss is significant, anion gap is not changing much, that means the ratio will come less than 1. That is NAGMA. So if bicarbonate is not at all changed, then bicarbonate is like 22 or something, change is only 2, but anion gap is significantly lower, like 8 or 10. So the ratio will come more than 2. That means there is high anion gap metabolic acidosis. But along with that, there is metabolic acidosis, alkalosis is there. So anything less than 1 is NAGMA, and delta ratio 1 to 2 is HAGMA, and anything more than 2 is HAGMA with metabolic alkalosis. Then you look at the osmolar gap. Any osmolar gap is more than 10, you look for isopropyl alcohol, ethanol poisoning, methanol poisoning, and salicylate poisoning. And one more thing, when you discover methanol poisoning, in that you can use pemiprazole, ethanol, and hemodialysis can be done. In salicylates, mainly respiratory alkalosis and metabolic acidosis is there. We already discussed all these causes. Now we goes in the case-based scenarios. So from this, pH is 7.43, bicarbonate is something, there definitely metabolic acidosis, there is some acidosis is there. ABG is not normal because pH is normal. 7.43, it is on the alkalemic side. PCO2 is 20, PO2 is 70. So there is alkalemic side. So the primary pathology is alkalemia. So what is the cause of alkalemia? Bicarb is low. This is acidotic state. So PCO2 is 20. That is the primary is respiratory alkalosis. So check for metabolic compensation. Expected bicarb is 20 because here the bicarb is 20. Let's say this is acute state. Acute for every 20 degrees for at least this expected bicarb is for every 20 degrees there is 2 into 2 for every 10 2 should be decreased. Here 20 is decreased, so 4 should be decreased. So expected bicarb is 20, but bicarb is 13 here. So there is a but bicarb is, so metabolic acidosis is also present in this case. So anion gap is 20, so delta ratio is 1.4. So from this side there is both alkalemia, there is respiratory alkalosis also, metabolic acidosis also. So this is so, though ABG pH is normal, there is significant changes in the PCO2 and bicarb. I'll again explain. pH is 7.43, it is on the alkalemic side, and why there is, since it is on the alkalemic side, the primary pathology is respiratory alkalosis. So PO2 is normal, bicarb, expected bicarb for compensation, you always look for the carbon. Since the bicarb PCO2 is decreased by 20, since it acute respiratory alkalosis, for every 10 there is change in 2, so 10 into there is 2, 20 is decreased, so 4 should be changed. So 24 is a normal, we expect bicarb around 20, but here bicarb is 13. That means some metabolic acidosis there. Then you calculate the anion gap. So anion gap is 20. So anion gap is high anion gap metabolic acidosis. You compensate, you calculate delta ratio also. Delta ratio is 1.4. So anything 1 to 2 in delta ratio is high anion gap. Anything less than 1 is normal anion gap. Anything more than this HAGMA with metabolic alkalosis. So this is a case of respiratory alkalosis with high anion gap metabolic acidosis. The primary pathology you always mention. So what is this cause of respiratory alkalosis and high anion gap metabolic acidosis? These are the visual possible clinical scenarios where respiratory alkalosis and high anion gap metabolic acidosis is seen. So first, high anion gap metabolic acidosis can be explained with renal failure with early pulmonary edema, pneumonia or ARDS. So any pulmonary edema, any pneumonia, any ARDS patient will have tachypnea. Because of the tachypnea there is respiratory washout. So CO2 washout. So that might explain the metabolic alkalosis. Renal failure will explain the hagma. DK will explain the hagma with pneumonia or any left ventricular failure that is causing the pulmonary edema or something, that can explain the respiratory alkalosis. So that is one more possibility. Diabetic ketosis with pulmonary edema. Pulmonary edema also will cause tachypnea. That can cause CO2. Pulmonary embolism. Sorry, that is not pulmonary. Pulmonary embolism. So pulmonary embolism can cause tachypnea, can cause CO2 washout. That can explain the respiratory alkalosis. D can explain the hyperagma part. Salicylate poisoning. I already mentioned one notorious presentation where respiratory alkalosis is the initial presentation that can in turn cause hagma in the later place. Salicylate poisoning is one more thing where respiratory alkalosis with hagma can be seen. So salicylate poisoning, this can be a case of hagma, where this can be a case of salicylate poisoning where respiratory alkalosis initial presentation, later on going into hagma as classically seen. Once again review this case when you get in alkalosis is there compensation. You should always review such cases. This is a good case scenario where these are all the possibility where both respiratory alkalosis and high anion gap metabolic acidosis are seen. So case 2. So pH is clearly 7.65. There is no doubt there is a acidotic state. PCO2 is 82. PO2 is 21. PCO2 is the respiratory acidosis is a possibility. Bicarbonate is also 14. Both metabolic and respiratory acidosis is a possibility. Sodium is 130 and chloride is this. So pH is epistemic. PCO2 is primary disorder is. So based on how much change is there. So 40 is the baseline cutoff. 82. This is almost increased by 100%. Bicarbonate is 14, 24, 10. It is not increased by 100%. So it is generally decreased around 75. So primary pathology, significant change is seen in PCO2. So we are taking primary is respiratory. So because more change is seen in PCO2 when compared to bicarbonate. So this is one more reason. And check for compensation. Expected bicarbonate, generally we expect in the respiratory PCO2, 82 is there, no? Generally for every 42 is there, no? 42 means it generally for every 10, we, in case of acute, if it's acute, we generally acute for every 10, 1 we expect. So 24, 28 we expect. So but here acidosis, but bicarbonate is 70 CO2. So actual bicarbonate is, so metabolic acidosis we are also suspecting. Anion gap is 20 here. Na plus Cl minus bicarb, what we check? You can calculate anion gap is 20. High anion gap metabolic is delta ratio is also 10 by 10 1. So anion gap, how you calculate? Anion gap is 20 minus 14 or something. Bicarbonate, so anion gap is 20 minus 12 or something, but 20 minus 14 which, anion gap is 20. Normal anion gap, since if you are including not including potassium, it will be 10 plus or minus 2. If you take anion gap difference as 10 and bicarbonate difference also 24 minus 14 is 10. 10 by 10 is 1. So again, I will again tell you delta ratio is calculated delta in anion gap. So if you take normal anion gap as 20, here anion gap is 20, normal anion gap is 10 or something, 20 minus 10 is 10, delta in is the change in the anion gap, that is 10. Bicarbonate change is 24 minus 14. So 24 is a normal and 14, the ratio is 10, high anion gap metabolic acidosis. So this is the case of respiratory acidosis with high anion gap metabolic acidosis. So why you kept respiratory is because the significant change is seen in the major changes in the CO2 is more change when compared to bicarbonate. Bicarbonate came from 24 to minus 14, 24 to 14, the change is 10, it is hardly 80%. But PCO2 increased from 40 to 80, there is almost 100% change is seen. So that's why I kept respiratory acidosis as a primary pathology, because PCO2 change is more when compared to bicarbonate change. So what is the possible mechanism? One, respiratory lactic acidosis with cardiac arrest, revived and respiratory failure. So this is one more mechanism where patient is having some lactic acid, that is explaining the hagma part, with cardiac arrest, that is also explaining and respiratory failure, that going into the severe respiratory failure. Once a patient is having like initially patient with hagma, what will happen is initially with metabolic acid, the patient tries to come with the respiratory alkalosis. So once after patient will become fatigued because of the continuous tachypnea and all, patient will go into muscle fatigue will come, patient won't be able to breathe properly. Then the patient will go into type 2 respiratory failure. Then the patient will develop respiratory acidosis also. So this might be a case of lactic acidosis with cardiac arrest. Some cardiac arrest is there that is causing the decreased perfusion, that is causing the hagma part. Initially patient was able to compensate with the respiratory alkalosis, and in later on patient is going into respiratory acidosis also. Any condition with metabolic acidosis and respiratory exhaustion, there is one more condition I explained. DKA in GBS. So in patient with the DKA, generally metabolic acidosis is there, no? In that patient, what will happen? Generally patient with metabolic acidosis will have tachypnea and ketotic breathing. So patient is trying to wash out CO2 and maintain the normal pH. If patient is having GPS and myasthenia along with, his respiratory muscles will be paralyzed. He won't be able to compensate. So both metabolic acidosis will be there, respiratory acidosis also will be there, because respiratory muscle fatigue is there. DK or renal failure in COPD patient. So DK and renal failure will explain the Hagma part. In COPD patient, they will already underlying CO2 retention because of the air trapping. So because of the obstructive lung disease there, no COPD will be there. So they have both metabolic acidosis and respiratory acidosis. So these are the conditions where both can be present. Metabolic acidosis, these are the possible clinical scenarios in this patient where it can explain the both respiratory acidosis and metabolic acidosis. So what is the indication? Generally in the case of metabolic acidosis, to maintain the hemodynamic stability, and generally why do we give bicarbs? To maintain the hemodynamics, because low bicarb also will cause cardiac myocardial contractility, it will affect the myocardial contractility, like metabolic acidotic state also will expect the myocardial contractility, and also cause severe metabolic acidosis won't be able to compensate by the respiratory alkalosis. So patient respiratory muscle will go into fatigueness. So to buy us more time, we give bicarb. Generally what we do is pH less than 7.1, we start giving bicarb to make it just around 7.1 to 7.2 or something. So in them we give bicarb to maintain just 7. We generally don't significantly correct. So any pH less than 7.1, you can give bicarbonate therapy to maintain the bicarb around 15 to 18 or something. Our target bicarb is around 15 to 18. So that to prevent the respiratory fatigue and to maintain the hemodynamic compromise. So any pH less than 7.1, we can then generally give bicarb. So if pH is more than 7.5, there is no AK also, then we generally kidney will try to compensate. So generally no indication for bicarb. If pH in 7.1 to 7.2 and AK is significant where they are present, then you can give bicarb. So I'll once again repeat, if pH is less than 7.1, you generally give bicarb to maintain bicarb around 15 to 18 to prevent the respiratory compromise and all. If pH is more than 7.1 and no AK is present, you generally wait on it because kidney will try to compensate. If pH is 7.1 to 7.2, if AK is there, severe AK is there, you generally give bicarb because kidney is not able to compensate. So that is the indication. pH less than 7.1 definitely indication. 7.1 to 7 is indication in the case of severe AK. If pH is more than 7.1, no AK is there, generally no indication is required. Case 3. pH 7.39, normal pH. PCO2 can be a mixed one also. So PCO2 is there, bicarb is 13. So this is acidosis, 7.3 bicarb is 13. This is acidotic condition. Primary pathology is metabolic acidosis. May be some compensation is there, whether it's properly compensated or not. Expected PCO2 after compensation is generally 27. So generally bicarb is decreased around 11 into it should decrease on 11 into 1.2, it currently 11 to 1.25, it should decrease around 13 or something. So it will come around 27 or something. PCO2 should decrease from by 13 or something, it will come at 13 or something. So 27 or something. So actual PCO2 is 22 in this case. So there is some amount of respiratory alkalosis also. So generally metabolic acidosis with compensation is generally patient doesn't go into significantly low. So actually it should come on to only 27 or something, but it is going into 22 or something. It is going further low. That means some amount of respiratory alkalosis is also there. It is not just being compensated. So there is a mixture of both respiratory alkalosis and metabolic. This is not no more compensated. It is a mixture of both metabolic acidosis and respiratory alkalosis. So if it is compensated, PCO2 will stay at 27 only. Then you can get compensated metabolic acidosis with respiratory alkalosis. So here both respiratory alkalosis is there, metabolic acidosis, because it is going below compensation. So metabolic acidosis and respiratory alkalosis is there. Anion gap is 38. So Hagma delta ratio is also more than 2. So metabolic alkalosis is also there. So in this case there are 3 different scenarios. So pH is normal in this case, but can you see? So then you look at bicarb. So pH is less than 7. As I told you, if pH is normal, bicarb is 13. You look at the what side of 7.4 it is there. pH is 7. It is on the acidotic side. So bicarbonate you check, it is a metabolic acidosis, the primary pathology. Then you look for the compensation. So bicarbonate is decreased by 11 into 1.25, it comes around 13, 14 or something. So the compensation it should come around 40 minus 13 or something, should come around 27 or something. So generally if it is 27 or something, we should have called it as a compensated metabolic acidosis with respiratory alkalosis. But PCO2 is going further low, less than 27. So underlying respiratory alkalosis is also present. So metabolic acidosis with respiratory alkalosis. Then you check for the normal, then you check for the anion gap. Anion gap is more than 20. So we thought anion gap metabolic acidosis is there. But anion gap is 38 something. So anion gap is significantly elevated. But bicarb is only changed by 11. So there is significantly 28 by 11. So change in anion gap is more when compared to the bicarb. So the delta ratio is more than 2. So metabolic alkalosis is also there. So in this is a case where 3 parameters are there, both respiratory alkalosis with metabolic acidosis. So respiratory alkalosis with metabolic acidosis and metabolic alkalosis. We'll look at the what are the possible. This is a triple acid base disorder where hagma plus metabolic alkalosis with respiratory alkalosis are there. What are the possible scenarios in this? So one, sepsis, decay plus vomiting. So any metabolic alkalosis, you should always look for the vomiting, because vomiting is one where the acid is excessively secreted, it will go into metabolic alkalosis. So in this case, there might be a sepsis that can cause lactic acidosis, and decay can cause metabolic acidosis because of keto acids. Maybe the patient is trying to compensate for metabolic acidosis with respiratory alkalosis. So patient is having metabolic acidosis and respiratory alkalosis. Because of the vomiting, patient is having metabolic alkalosis also. So these three will explain. So DK explain the metabolic acidosis, high anion gap metabolic acidosis part. Because of compensation, the respiratory alkalosis is there, and because of the vomiting, metabolic alkalosis is also there. So this one case scenario where DK plus vomiting is where you can patient will have initially patient is presenting with the DK, where patient will have hagma initially. Because of the compensation, patient will develop respiratory alkalosis also, and the patient will have some amount of vomitings also. In that, the patient will go into metabolic alkalosis also. So where three disorders with hagma plus respiratory alkalosis with metabolic alkalosis. One more possibility is ARDS plus renal failure plus vomiting. ARDS will cause respiratory alkalosis because of the tachypnea. Renal failure will explain the metabolic acidosis, hagma part. Vomitings or diuretics will explain the diuretics will cause dehydration again. So diuretics can cause bicarbonate loss also. That will also explain the metabolic alkalosis. So one thing I'll say, any metabolic cause, always look for the vomitings and diuretics. So CCF and diuretics and DK. So CCF and diuretics will explain the metabolic alkalosis part. DK will explain the metabolic acidosis part. Along with that, there is a compensation in the respiratory part, that will explain the respiratory alkalosis part. So salicylate poisoning with vomiting. Salicylate poisoning will explain the respiratory alkalosis, initial respiratory alkalosis, and high anion gap metabolic acidosis with vomiting. So vomiting will explain the metabolic alkalosis part. So that will explain the three triple acid base disorder. This classically seen in bulimia and nervosa patients where because they ingest something and they keep returning to vomiting or something. So this is one more thing. A 24-year-old male with family history of recurrent hypokalemia, pH is 7.1, bicarbonate is 13, anion gap is 12, urine anion gap is positive. So there is acidosis, there is hypokalemia, there is acidosis, anion. When you look at the acidosis, you look for bicarb. So metabolic acidosis is there. There is normal anion gap metabolic acidosis 10 to 12 is normal. And you look for the in the case of in the case of normal anion gap metabolic acidosis, you look for the urine anion gap. Urine anion gap is positive, that means RTA is a possibility. Then look for the hypokalemia is there, so it might be a probable case of distal RTA or proximal RTA. So since there is a significant bicarb low, this is probably a case of distal RTA. You give initially distal RTA, you give potassium correction, then followed by bicarbonate correction, 1 to 3 milligrams per kg. A case of 50-year-old male who underwent intestinal resection for malignancy, now presented to OPD with an ABG of pH 7.15, bicarbonate of 17 and platelet of 0.9. So in this case, pH there is significant acidosis, bicarbonate is only 17. I will mention PCO2 also. PCO2 is also around 35 or 36. It is, and I will mention 40. Let's say PCO2 is 41, 42. So there is no significant respiratory residuals. I am mentioning there is no significant respiratory residuals also. So bicarb is only 17. Why will explain 7.15 of pH? What is the cause? So this is one of the case of short bowel syndrome where this intestinal bacteria has grown. So in them the whatever carbohydrate that is there, no, so that is converted into the carbohydrate which is malabsorbed or something which is converted into D-lactates, which cannot be detected in the normal blood levels. So that is why lactates levels are normal, but ABG is showing pH of metabolic acidosis. This is due to the D-lactic acidosis. That is due to the short bowel syndrome. That can be seen in D-lactic acidosis can be seen in the short bowel syndrome, and any gastric bypass, any DKS, propylene glycol poisoning, any chronic intestinal malabsorption syndrome sometimes. They can all be cause of D-lactic acidosis, which cannot be detected in the normal blood. A 40-year-old male admitted in the view of alcohol withdrawal due to severe withdrawal symptoms. Patient was put on the intravenous diazepam therapy, and pH is 7.1 and bicarbonate is 14 and anion gap is 23 and osmolar gap is 23. So intravenous diazepam. So this is a case of propylene glycol poisoning. So in this, because of the intravenous infusion, they have a diluent as propylene glycol. They have pH is 7.1. There is acidosis definitely. Metabolic acidosis because bicarbonate is 14. High anion gap metabolic acidosis. Osmolar gap is also positive. When osmolar gap is positive, you only think of 4 or 5 causes. There is methanol, ethylene glycol, ethanol poisoning, isopropyl alcohol, salicylate. Since the patient is having symptomatology of intravenous diazepam poisoning, probably case of propylene glycol poisoning, you withdraw the drug. If required, you can go for dialysis also. Thank you.